Hi, this is Kelly Krohn. I'm giving an update report on things that I've learned today in the bone field. It was a little busier today. We actually had some nice sessions. We had several posters. We're hoping to put some posts on later tonight. I want to cover a couple of major presentations this afternoon. Dr. Ken Saig spent about 45 minutes talking about the complications of treatments in osteoporosis. This is a tough field where we have effective drugs, but there are rare complications. And I thought Ken did a very nice job putting in perspective rare things like osteonecrosis of the jaw and atypical femur fractures. I'll point out a couple pearls that I learned. Osteonecrosis of the jaw, certainly it happens. It's rare in doses of the drugs that we use for osteoporosis, like oral bisphosphonates and denosumab. And it can often be prevented if we work together with our dental colleagues. So holding off on starting osteoporosis medications until the dental work is completed, I think, is the best pearl. And then working with your dental colleague and your patient to ensure good dental hygiene. I think that osteonecrosis of the jaw can be an incredibly rare adverse event when using these anti-resorptive drugs. The other big issue in the room is atypical femur fractures. Once again, incredibly rare in the doses that we use to treat osteoporosis, but it's a real entity with anti-resorptive drugs. And I think the data is showing that yes, we can give a holiday or a sabbatical, but if we keep people off therapy too long, then there's a return to an increased risk of fractures. So it's an area of clinical judgment and informed decision making with your patient to determine how long you should stay on these anti-resorptive drugs and if you should take them off for a short period of time, and then selectively possibly resuming a drug really in a fairly short period of time. I liked one idea that Ken talked about today. It was the concern about the healing of fractures with bisphosphonates. I work in an orthopedic practice. This comes up pretty routinely, and I think the literature's pretty good that oral bisphosphonates do not seem to impede the healing of fractures. There may be one caveat. If you have somebody who's had a fracture in the last couple of days and you give intravenous bisphosphonate like zoledronic acid, 99% of the medicine will go to the site of the fracture, and that may impede healing. On the other hand, a little oral bisphosphonate slowly over time does not appear to impede fracture healing. The second talk this afternoon, I'll just briefly cover. It was actually quite complicated. Dr. Susan Ott's a wonderful nephrology bone person from the University of Washington, and she knows a ton about chronic kidney disease and the treatment of osteoporosis. A few pearls that I learned from Susan. If people have up to stage 3 chronic kidney disease, really the data and the safety of our drugs is pretty similar to those who don't have kidney disease. On the other hand, if you have end-stage kidney disease, amateurs should not be treating osteoporosis with these drugs. Leave it to our kidney colleagues who have some expertise in bone health. Susan showed nicely, in my opinion, that denosumab does not, you do not have to adjust the dose of denosumab in people with chronic kidney disease, but you can get into real big trouble real fast. So some of these people with chronic kidney disease given denosumab have had very serious hypocalcemia. So I think the pearl is, don't treat people with end-stage renal disease with these osteoporosis drugs. I look forward to, there's a few postings from some other posters and abstracts today. We'll try to make some comments tonight, and we'll update you again tomorrow. Thanks.